Thank you for having me. Are all of these mics working? Good. Okay. All right. And then how do I start you're starting it for me? Well, thank you for having me. I did not know that I was going to get such a good introduction. So I have sort of an introductory slides about myself, so we can kind of blow through those. But today I'm going to just try to focus on urinary and sexual health. Those are both still very wide topics, so focusing primarily on urinary tract infections, the different types of urinary incontinence, and then sexual health at the end. If you have any questions or anything about other topics, I'd be happy to answer those for you, but I'll try to focus on these for now. And then, what do I do with this? It's not going. It is not going. Okay. So this is I've been in Fairbanks for about a year, a little over a year now. Prior to that, I was the Associate Program Director at Cedars-Sinai Medical Center in Los Angeles, so a very different practice pattern. So if you see me during the week, I'll look a little bit more like this, and then if you were to catch me on the weekends, this is my weekend outfit. So outside of urology, my other big passion is skydiving. So it's just a little bit about me, but going into urology, what is urology specifically? Urologists see both men and women, specifically for diseases of the urinary tract, and then the male reproductive system as well. Urologists treat a very wide variety of conditions. Because of that, there's a lot of subspecialization in urology and different fellowships that you can undertake. So these are the main subspecialties that are in urology, and I did a combined fellowship in sexual medicine and reconstructive urology. So I believe I'm the only reconstructive urologist in Alaska. There are some procedures that I can offer that I'm very comfortable with that I don't believe were being offered here before. So a few of those we'll touch on today, but there's a lot of different things that we can do about incontinence and sexual health. So I'm going to start off just talking about urinary tract infections. This is probably the most common thing that people come to see me for. About 50 to 60% of women will get a UTI in her lifetime, and 10% of women annually. So you can tell with those numbers that there's a lot of women who are getting multiple UTIs. So 40 or 50% of people are not even experiencing them, and there's an unfortunate group that experiences them quite frequently. Men, it's about a 12% risk lifetime, and this increases with BPH, which is the benign growth of the prostate. BPH is extremely common. About 50% of men by age 50 and about 92% of men by age 80 will have difficulty urinating because of their prostate. When the bladder can't empty all the way and the urine is just sitting there, it's a great place for bacteria to grow. So people who didn't used to get UTIs will start to get UTIs kind of with age. The most common cause of urinary tract infections is E. coli. And so a lot of times people will get their first UTI and they'll hear that it's E. coli and they'll freak out and say, I'm really clean, I don't know what happened. That's just the most common cause of urinary tract infections in general. There are several other types of bacteria that can cause urinary tract infections. I did want to draw your attention though to these two at the bottom. So these are bacteria that can cause urinary tract infections but do not grow on standard urine cultures. They take about 6 weeks to grow. They don't have a cell wall. So there's a lot of times that people have these infections and they don't get picked up with a standard urine culture. And I've seen several people who had been diagnosed with bladder pain syndrome, which used to be called interstitial cystitis, that had been having bladder pain for years. We test them for these bacteria. And then sometimes that can be treated and the pain will go away. So those are two kind of newer things on the scene that can cause urinary tract infections that don't often get picked up. So for recurrent urinary tract infections, this is defined as 3 UTIs within 12 months or 2 within a 6-month period. Ideally, we want to first look and see if there is a source of this. Is there a kidney stone that's harboring bacteria? Is there some sort of anatomic abnormality, a little urethral diverticulum or a little pocket where bacteria can stay? Because if there is a source for it, the goal is to identify and treat the source rather than just giving rounds and rounds of antibiotics. There are a lot of non-antibiotic things that we can do for urinary tract infections, and I'll talk a little bit more about that later. And then sometimes we do have to do antibiotic prevention. We try not to use antibiotics whenever possible. There's a huge problem with antibiotic resistance, especially in people who get recurrent UTIs who just get treated over and over with different types of antibiotics. But sometimes we do have to resort to that. There are a lot of different conditions that can get mistaken for recurrent urinary tract infection. Probably the most common one is something that we'll touch on in a bit more detail, something called genitourinary syndrome of menopause. Pelvic floor dysfunction is another one. It can cause a lot of the same symptoms of urinary tract infection. Overactive bladder, bladder pain syndrome, and then unfortunately bladder cancer as well. And women have been found to have a delayed time to diagnosis for bladder cancer, oftentimes getting labeled as recurrent urinary tract infections or bladder pain syndrome, so that's something to keep in mind. It's rare, but something that needs to be in the sort of list of possibilities and make sure that that's not something that we're dealing with. Genitourinary syndrome of menopause, this is something that happens after menopause. The lining of the vagina changes and becomes thinner and starts to atrophy. The urethra, the vagina, and the anus all become closer together. And this has a lot of symptoms, including burning with urination, urgency, frequency, vaginal dryness, pain with intercourse, and urinary tract infections. The reason that this causes urinary tract infections is that the lining of the vagina will start to atrophy. Prior to menopause, there is a bacteria called lactobacillus that lives in the vagina in very high concentration that's very good at preventing urinary tract infections. And then after menopause, as the lining of the vagina changes, the lactobacillus concentration goes down, and people who were not susceptible to urinary tract infections previously can start to get recurrent infections. The main treatment for the genitourinary syndrome of menopause is the use of a vaginal estrogen cream. And so I'll give you my whole spiel because I give this to everybody who comes in. When we're talking about the vaginal estrogen cream, we're not talking about hormone replacement therapy with injections or pills. This is a cream that works locally on the tissues in the vagina to help restore the tissues in the vagina to the premenopausal state. As that starts to get restored to the premenopausal state, a lot of these symptoms will start to abate, and then the lactobacillus concentration will increase, which will decrease. This is our best weapon against recurrent urinary tract infections in postmenopausal women. When you're using a local topical vaginal cream, this estrogen does not get absorbed by the body in any significant amount. This is even safe to use in women who have breast cancer, even estrogen receptor positive breast cancers that have to avoid estrogens. And it's also recommended even in women who are using hormone replacement therapy to still be on a topical vaginal estrogen cream to help with this. Pelvic floor disorders are another big cause of these sort of pelvic pain symptoms. And that's the thing that anytime, if people have pain, for example, in their arm or in their leg, they don't automatically jump to infection as the most likely source. But when people have pelvic pain, they typically think that this is due to infection. And it does lead to a lot of people getting just repeated courses of antibiotics over and over, which can be a big problem for them in the future when they develop resistance. But the pelvic floor disorders, the pelvis is just a giant bowl of bone and muscle. And so there's a lot of nerves and muscles that can have problems like there can be in any other part of your body that can cause pelvic pain and pressure, urgency, frequency, pain with intercourse, etc. Pelvic floor physical therapy can be a really good treatment for this. And so I think we have as many or more pelvic floor physical therapy places here as we did when I was in Los Angeles. So there were 8 million people vying for that many pelvic floor physical therapy spots. And then here we have just an absolute wealth of really good pelvic floor physical therapists. I send people to pelvic floor PT for bladder pain, for incontinence. It's helpful after prostate surgery if there's any leakage. So this is something that we actually have a really good network for here in Fairbanks. I'm going to get on my soapbox a little bit for antibiotic resistance. This is something that I see a lot as a urologist, and anytime someone has urinary symptoms, and then it's very easy to go online and see a telemedicine doctor and not get a urine culture and get antibiotics. Resistance is a global health crisis. It's one of the biggest threats to humanity, in my opinion. So as people get exposed to more and more antibiotics, those bacteria will start to develop resistances, and those antibiotic classes can be no longer effective. It's estimated that in the United States, up to 68% of antibiotics are used inappropriately. And we also have a lot of antibiotics in our food supply, and it's a lot of things that can be contributing to this. So anything that we can do to decrease your chance of developing antibiotic resistance. It can be frustrating for people when they have a UTI and they call and I say, go to the lab, get a urine culture. We want to make sure we know what we're treating. We want to make sure we're not missing something, and we need to know what is effective against it. But that's the main thing that we are trying to prevent here. So once you run out of oral options, which happens kind of sooner and sooner, you're then condemned to IV antibiotics for a while, as long as those work. And I have seen several patients who were just resistant to everything, and we don't have antibiotics that can be effective for them. So that's my soapbox on antibiotic resistance. But anytime, if you think you have a UTI, it's really important to get a urine culture. We treat based on the urine culture. In the meantime, some NSAIDs can help. There's a medicine called Pyridium. It's available over the counter, and a lower dose called Azo. It will turn your urine neon orange, but it is great to help with the symptoms in the meantime while we're waiting on your culture results. And I also have a lot of people that will come in and say, oh, I think I had an infection and I didn't get a long enough course of antibiotics. This is the AUA guideline recommending that we generally don't treat for longer than 7 days, and oftentimes 3 to 5 days can be sufficient. So of non-antibiotic prevention strategies for recurrent UTI, for postmenopausal women, the low-dose vaginal estrogen is the best thing that we can do. There's a lot of things that I recommend to people that have been shown to have some maybe mild efficacy, maybe will help you, are unlikely to hurt you. But probiotics, cranberry extract is the thing that has probably the most evidence behind it. Vitamin C, there's something called D-mannose. The way that cranberry extract and D-mannose work are by preventing the little hairs from E. coli specifically from adhering to the bladder wall. So if you tend to get infections with different types of bacteria, it's probably not going to do a whole lot for you to take these. E. coli is the most common cause of UTI, so it can be really helpful, but if you know that you're one of those people that gets enterococcus over and over, and then you buy Eucora, you're probably just giving yourself really expensive pee, but it's something that might help, probably won't hurt. The other thing is getting rid of any source of urine stasis, meaning that the urine is just sitting there. So if there's an issue with an enlarged prostate or a blockage or a stricture, and the bladder can't empty completely, that's a great place for bacteria to sit and grow, and that can cause a lot of these recurrent infections. And if there's a stone or a foreign body or something in there that's contributing to this, eliminating that can help. If you want to take a picture of this, this is typically what I recommend to people, the doses and frequencies of the different types of non-antibiotic prevention methods. But D-mannose, the cranberry extract, taking the ocean spray cranberry juice won't help, and you have to drink a whole lot of the really gross, pure, unsweetened cranberry juice. So I oftentimes tell people just to take the cranberry extract pills, which you can get over the counter. A probiotic containing at least 3 types of lactobacillus. Most probiotics that are marketed as women's probiotics are marketed that way because they have a lot of different types of lactobacillus in there. So that's kind of an easy way to figure that out. So I just want to make sure, I think we still have one person getting a picture, so I want to make sure before we move on that she's able to get it. All right, UTIs in men, totally different cause. Men have much longer urethras than women. It's typically difficult for bacteria to get from the outside world all the way into the bladder. That all changes with BPH, or benign prostatic hypertrophy. So as the prostate grows, it starts to pinch off the urinary channel. The prostate is a gland that sits between the bladder. The urethra runs through here, and this is where the urine comes out. Sometimes, so it's not just the size that matters. We don't do a whole lot of, I don't know, maybe a lot of you have had a lot of exams where there was a finger in the rectum and feeling the size of the prostate. We don't do a whole lot of that anymore. There's a lot of different ways for the prostate to grow. I've seen people with really small prostates that grew in such a way that it completely just blocked the urinary tract and they can't pee. And I have seen people with absolutely grapefruit-sized prostates that grow out this way, and it doesn't seem to cause them, very much in the way of problems. But difficulty with urination, And UTIs in men are often caused from incomplete bladder emptying from prostate growth. So the ways that we treat this is a super common problem, and there's a lot of different ways that we can treat it. I would say most people start with medication, and then if those become ineffective, there are a lot of different surgical options that are available. For the medications, the most common one we use is something called Flomax. So Flomax will help relax the bladder neck and allow the urine to flow more freely. Main side effects of Flomax, about 10% of people will get lightheaded if they stand up really quickly. So we generally recommend people take that at night when they're going to be laying down anyway. And then it also causes something called retrograde ejaculation. So what that means is when you ejaculate, the semen is going to take the path of least resistance, which is usually forward and out through the end of the penis. But with Flomax and with most prostate surgeries, the path of least resistance is now backwards into the bladder, which is not a big deal. You just pee it out when you pee. But you may not see anything come out when you have an orgasm, and that really freaks people out if they don't know to expect that. So I like to make sure everybody knows that that's a normal side effect of Flomax. One of the other medications is Cialis, and so Cialis is a medication that was developed primarily for erectile function. There's a higher dose that you can take as you need just to help with erections, and there's a low dose that you can take every day that helps with erections and with urination. So for a lot of people, that can be a great two birds, one stone type medication. And then finasteride. So Flomax and Cialis will help with the symptoms, help make the urine be able to be evacuated more easily. Finasteride will actually treat the problem, and it will allow the prostate to shrink. Finasteride has good side effects and bad side effects. On the good side effects side, it's also marketed as Propecia to help prevent hair loss, so people who are taking it can keep that lovely head of hair. Negative side effects, people complain of hot flashes, tenderness in the chest, and a decrease in their sex drive, and there's a small minority of people that feel like that was permanent for them even after they stopped the medication. Once those are no longer working, there's a lot of different surgical options that are available. The optimal procedure is going to depend on your prostate size and shape, and then patient, your preferences. Is maintaining ejaculatory function really important to you? There's some things that are available currently that can help keep that. Most of the prostate procedures involve, if you think of the prostate like an orange, you've got sort of the meat of the orange in here and then the peel of the orange on the outside. The nerves that control erections run along the outside of the prostate. When someone has prostate cancer and they get surgery, we take out the whole orange, the meat and the peel. When someone doesn't have cancer and we're just trying to help with urination, most of the procedures involve carving out the blocking part of the meat of the prostate, leaving the peel intact, which is where all the nerves are. So should not have issues with erections, incontinence, which can be more common after prostate surgery. This is something that I feel like is important to address. We used to think that the bladder was a sterile environment, and we know now that it's not. So when people get urine cultures, I strongly recommend that people don't get urine tests if they're not having any symptoms. If there's bacteria present on the urine culture and you're not having any symptoms, you may be what we call colonized with bacteria. It may not be causing an actual infection. This is something that we recommend not treating, except if you're pregnant or if you're scheduled to have a urologic procedure. If somebody's going to be in there mucking around, we want to make sure that there's not any bacteria present. But the question I get often is, should we just check? Should I just check and see if I have a UTI? Emphatically, no. If you're not having any symptoms, then don't check, because you may find something that doesn't necessarily need to be treated. We'll move on and start talking about incontinence. So urination is a really complicated process that typically starts with something called the pontine micturition center. So typically what is happening is this: you get a signal from your brain that is consistently telling your bladder, don't pee, don't pee, don't pee. And then when you kind of give that, when you're in a place where it's socially acceptable to urinate, a couple of things are supposed to happen. When you start to urinate, the bladder muscle will start to contract, and then the urinary sphincter should relax at the same time. So when people think of sphincters, oftentimes we think of the anal sphincters, but you have sphincters for the bladder as well. It's that muscle that you squeeze if you want to stop peeing. So the bladder muscle needs to contract and the sphincter muscle needs to open at the same time for you to be able to urinate effectively. There's a lot of different ways that this can go wrong. And there's a lot of different types of incontinence. So we'll touch on most of these. The most common ones are something called urge incontinence and stress incontinence, so I'll focus primarily on those. But they happen for different reasons and they're treated very differently. So urge incontinence is something that happens when the bladder muscle squeezes without permission. So when that happens, it's basically like a muscle spasm, but it's happening in the bladder. And if the bladder is fairly full, or depending on the strength of the contraction, it can cause overactive bladder, which is what we call that urgency frequency. I have to go right now, I have no warning. Or it can cause urge incontinence, where you have leakage of urine because of the bladder spasm. There's something that we call stress incontinence that happens, they have similar symptoms, which is leakage, but it happens for a totally different reason. It doesn't have really anything to do with the bladder muscle squeezing without permission, but anytime there's an increase in abdominal pressure from coughing, sneezing, laughing, running, that sort of thing, the sphincter muscle is too weak to stay closed because of that increase in pressure, and so leakage can occur because of that. So these are treated very differently, which is why I wanted to stress how different they are, or stress the differences between them. Urge incontinence is best treated with medications, and stress incontinence is best treated with pelvic floor physical therapy and surgery. So of the treatments for urge incontinence, we have a lot of them. The most common ones are oral medications. So when it comes to medications, there are two main classes. We have this class called the anticholinergics. They've been around for a long time, super affordable, ton of side effects. Dry eyes, dry mouth, constipation, and then recently with the entire anticholinergic class, which includes all kinds of medications, allergy medications, reflux medications, et cetera, there's been a black box warning for a possible association with dementia. So we try not to use these medications whenever possible. There is a new class of medications called the beta-3 agonists. These medications are fantastic, really minimal side effects, incredibly expensive. So it can be difficult choosing between these medications. Since that dementia warning came out, we've had a lot better luck getting, especially Myrbetriq, covered by insurance. It's been out for over 10 years now too, so that one we can sometimes get, but expensive to the tune of over $400 a month. So when we're talking about something like which tends to be a lifestyle, overactive bladder and urge incontinence are generally not dangerous, but they can be really socially uncomfortable. Sometimes the treatment can be worse than the disease, depending on which medications are available. There's something that we can do. We can just inject the bladder muscle with Botox. It's a really great, it helps for people with really severe incontinence or people that don't want to take medications or can't for some reason. It lasts for about 4 to 6 months, and then like Botox and any other muscle, it wears off and needs to be redone.
Could you say what's wrong with the first ones again? I thought you said that they're no longer advised.
No, they're still advised and they're still in use, but I like to make sure. Yeah, so commonly dry eyes, dry mouth, and constipation, which we've all known about for a while, but then a recent warning for a possible association with dementia. So typically once people hear that one, they say, no, thank you, I'm okay. There are some medications in this class that are of a structural composition that they don't cross the blood-brain barrier, so we think that they're unlikely or less likely to cause dementia, but there's not been any studies on those specifically, so I always warn everyone. There are some that I think are safer than others. Vesicare and Toviaz, kind of probably safer than Ditropan, but can I look you in the eye and say 100%, no, this one specifically is not associated with dementia? I can't, but those are some of the ones that are available. With bladder Botox, it's a procedure that we can do in the office. Downside of that one, about 10% of the time it works too well, and then you can't pee at all. And the downside of that is that also lasts 4 to 6 months until it wears off. So I don't ever do this on someone unless they are accepting of the risk and understand that they may be catheterizing themselves until it wears off. So that's for the people that it works really, really well for. It's fantastic. For some people, it can be a frustrating 4 to 6 months until the Botox wears off. There are some nerve stimulation treatments. There's something called PTNS. That's typically a weekly treatment for 12 weeks and then once a month in the office. So a lot of times people some people have modest effects with it, and it's difficult to get to the doctor's office that frequently. And then there is something called InterStim, which is like a bladder pacemaker, and it can help with overactive bladder and underactive bladder, interestingly. It's a 2-stage surgical procedure. I think there's one person in Alaska that does this. She's in Anchorage. It's Dr. Wang in Anchorage. So stress incontinence. So this is the coughing, sneezing, laughing type of leakage. Some of the risk factors are increased BMI, smoking, chronic constipation, so a lot of straining that can weaken the pelvic floor, chronic cough. Typically we see this in women who have had children and in men after prostate surgery. So stress incontinence can become very common. And there are a lot of treatments for stress incontinence, and so these range from really non-invasive to sort of complete reconstructions, but there's a procedure, there's an injection of something called Bulkamid. It's basically like the same thing that you would inject fillers for lips or face with. This is a minor endoscopic procedure. It can be done in the office or the OR. It works right away, no downtime. That substance, it's hyaluronic acid, typically lasts, they say, for around 7-ish years, and then it may need to be redone. So that can be a really good option for people, especially with minor incontinence. If you're going through 6 to 8 pads a day, it may not be enough. We haven't burned any bridges if we try it and it doesn't work. But especially for people with leakage of 1 to 2 pads per day, it can be a great procedure. Mid-urethral sling, they make these for both men and women. It's an outpatient procedure, typically about 4 to 6 weeks of healing. We put the sling in. It provides some extra support under the urethra to help keep it closed. This is a mesh. This is not the vaginal mesh that got the bad rap about 20 years ago. This is something completely different, was not part of the recall, but that can be helpful. I do this more often in women than men. In men, they do make mid-urethral slings. It is not good for men who've had radiation for prostate cancer. Slings can actually make the leakage worse. There is a new type of treatment called PROACT. This one is pretty new on the market. Also a minor procedure. It basically is 2 little balloons that get inserted where the prostate used to be. So this is most commonly done in men who've had prostate cancer and had their prostate removed. But these little balloons are inflatable and adjustable. So the nice thing about PROACT is there's little ports that are in the scrotum. If you start leaking again, we can put a little bit more fluid in the balloons and give it a little bit more pressure. If we did too good of a job and you can't pee, we just take some of the fluid out. So that's what's nice about the PROACT, is that it's adjustable. And it also works really well for most degrees of incontinence. The artificial urinary sphincter, this is what we consider the gold standard procedure. It's good for all types of incontinence, even really severe incontinence. Basically, it's a 3-piece device. There's a cuff that in its baseline state stays around the urethra and stays inflated so that the urine can't escape. And then when you want to urinate, there is a little pump in the scrotum that you pump, and it opens and the urine flows out, and it closes on its own in about 60 to 90 seconds. So this one is really good for men especially who've had prostate cancer, have leakage, okay for people who've had radiation. Radiation does put you at a slightly higher risk of complications for most procedures, but this is a really great one. So this is something that a reconstructive urologist offers. All of these procedures are things that I offer.
Question.
Yes?
You say 6 weeks recovery, what does that entail, or what does that mean?
So don't lift anything greater than 10 pounds for 6 weeks, no sexual activity for 6 weeks, and I generally ask people not to go into any bodies of water, bathtub, ocean, jacuzzi until the incisions are totally healed. No. Another thing that's important to know about the artificial sphincter is that for 6 weeks after the surgery, you will still be leaking. The reason for that is when we put it in, it has to heal open. If we have it heal closed, it'll never open and you won't be able to pee. So it heals open, we keep it deactivated. We let everything heal for 6 weeks, and then 6 weeks after your surgery, you come in, we activate the device, and you'll be dry after that. That's a good question, something I always like to mention. Urinary retention and overflow incontinence. This happens when the bladder is not able to empty. It can mimic overactive bladder because typically what we see is people feel like they have to urinate all the time and they leak and they're leaking all the time. So when we talk to people about this, they say, no, there's no way I have urinary retention. I pee all the time or I'm leaking all the time. But what happens is a normal bladder can hold about 400 to 500 milliliters worth of urine. And then when it empties, it's supposed to empty down to 0. And you've got 400 to 500 milliliters worth of time before you need to pee again. When someone has urinary retention, whether it's sort of partial or complete, say for example, they empty and they still have 200 milliliters worth of fluid in their bladder, you only have half the time before the person sitting next to you, before you're completely full and need to pee again. And when the bladder is completely full and it can't hold anymore, it'll just leak out, kind of like a water balloon that's holding as much as it can. So this can happen because of infection, blockage, whether from the prostate, whether there's stricture, which is scar tissue within the urethra. Severe prolapse can kink off the urethra, and prolapse in women where the bladder starts to come out of the vagina. There's a lot of neurologic conditions. Diabetes can do it. Constipation is also one of the most common causes of urinary retention. So the pelvis is, like we talked about, a giant bowl of bone, and it's got to share space with the rectum, the bladder, and then in women, the vagina. So if the rectum is completely full and you're very constipated, it can press on the urethra and make it difficult to urinate. So if constipation tends to be an issue for you and you're not able to empty your bladder, treating the constipation first will probably give you the best result.
I'm sorry, another question.
Sure.
Can sometimes having a surgery where you get an anesthetic trigger maybe a problem that's not there, aggravate it?
Definitely. A lot of times it's kind of the straw that breaks the camel's back. So people who are kind of not peeing great in the first place, and then anesthesia kind of goes over, kind of is the last straw, and then they can't pee. But it can happen even in people who don't have any problems with urination. But anesthesia definitely can cause. There's typically a lot of opioids involved with anesthesia as well, which can cause both constipation and urinary retention on their own. So that's fairly common. Yeah.
What's your recommendations on constipation? There's lots of over-the-counter.
That's a really good question. I usually recommend Miralax to people. That you can take kind of a nearly unlimited amount of it, and it's really nice because if you're really constipated, you can take 2 capfuls, and then the next day you can just take a half or whatever you need. It's very easy to titrate. It's not like, I generally don't recommend Senna. You can kind of become dependent on Senna to be able to have a bowel movement, but Miralax tends to be my first recommendation. All right, nocturia, or urinating at night. So a normal amount of urinations, about 7 times during the day, and then 0 to 1 time per night. So if people are urinating a lot at night, I get a lot of people who come in and say, I am not getting any sleep. I'm getting up 5 to 6 times a night. It's ruining my life. I can't sleep at all. What tends to happen, there are some urologic causes of nocturia, so overactive bladder can cause that. That typically happens during the day and at night. So if you don't have overactive bladder during the day and you're just peeing a lot at night, that's probably not overactive bladder. A lot of times people think that they're peeing a lot at night because of their prostate. The main reason for that would be if your bladder doesn't empty, right? And so you only have half the amount of time before it's full again and you have to pee. But you can have an enlarged prostate. If your bladder empties, it shouldn't really be contributing to this nocturia. Typically, what happens, so at night, our bodies make something called antidiuretic hormone so that we don't make urine at night and we can sleep through the night. But anytime that we have disrupted sleep, whether you're a light sleeper, you're moving around a lot because of pain, sleep apnea is probably the biggest cause. Every time you wake up, that antidiuretic hormone level goes down, your body starts making more urine, and then you have to get up to pee. So a lot of times people think that they are waking up at night because they have to pee, and the reality is they have to pee at night because they have poor sleep and they're waking up a lot. So a lot of times what we will do is send people for a sleep study. And so a lot of times we'll see some undiagnosed sleep apnea, and treating that can help with the peeing a lot at night. There are some conditions where people make too much urine at night. There are some hormonal treatments. It's basically antidiuretic hormone that you take at night so that you don't make a whole lot of urine. But it's typically, even though this is one of the most common reasons people come to a urologist, not generally a urologic problem. All right, I have a little bit of time to talk about sexual health. So the normal sexual function there's typically what we consider a sexual response cycle. So you have this initial desire and excitement phase. So the heart rate increases, blood pressure increases, genital arousal occurs. So this is causing erection in men and vaginal lubrication and clitoral swelling in women. There's the plateau phase where the arousal intensifies. The orgasm phase, which is the rhythmic contraction of pelvic floor muscles in both sexes, and then the resolution phase. So there's a lot of different places where this response cycle can go wrong or be frustrating to people. And I included in here, sexual activity should be pain-free. So if you're having pain with intercourse, that's not just a normal part of aging. That's not just something that you have to deal with. There are things that we should look into and treat so that this can be a pleasurable experience. There's a lot of different types of sexual dysfunction in men and in women. One of the things that can happen is just a low libido or a loss of desire. So this can be as a result of low testosterone. That's one of the things that can cause it. There's a lot of medications that affect libido. Lifestyle factors, relationship issues can all play into this. There's the inability to obtain erections and the inability to maintain erections, and so sometimes those go hand in hand. One of the things that I typically ask people is, do you still wake up with erections in the morning? So if you're waking up with erections in the morning, the plumbing works, right? The arteries, so basically what happens is the arteries will increase blood flow to the penis, it becomes erect. That erection will squeeze off the veins to the penis, which are around the outside, and so then the blood stays there and the erection stays. Sometimes, as people age, the clogging of the arteries that can happen when people get a heart attack, the same thing can happen in the penile arteries, which are much smaller than the arteries to the heart. So a lot of times, erectile dysfunction will often be a precursor, a warning sign that there may be some issues going on with the heart. So if you're still getting erections at night, the plumbing still works, right? The arteries are able to get blood flow into the penis. If it's just with partnered activity or partnered and masturbatory activity, there can be, that tends to be more of a psychological issue, which can still be treated with medication. But it's a really, erection and arousal are a really complex process. And so there are some medical reasons and things that we can do to treat it, and some relationship issues, psychological things that we can do to treat it as well. Premature ejaculation can be really frustrating for some men. There are medications, we typically use medications for this. The medications that we use are typically antidepressants, because people who are on antidepressants, they have an unfortunate side effect of a delayed orgasm or sometimes inability to orgasm, so we can use that side effect of that medication and kind of repurpose it, and it will help with premature ejaculation. So that's one of the things that we can do for that. Delayed orgasm or anorgasmia, there's a lot of different things that can cause this. Medications are a big cause. There's a lot of psychosocial factors and relationship issues can play a part. But there are a lot of different medications. The treatments are not, there's a lot of things that we can try. There's not just like a one and done medication that will take care of this for you. We talked about retrograde ejaculation. I'm going to step aside and get my water. We talked about retrograde ejaculation, which tends to be a common side effect of prostate medications and prostate surgery. And then there's something called Peyronie's disease. I don't know if you've seen any of the commercials with the bent carrot or the banana, but it's due to plaque formation in part of the penile tissues. And then that shrinks and contracts, and it causes curvature in that direction. So when it's severe, it can preclude sexual activity. It can make urination very difficult. I've seen people with a complete 180 in terms of curvature. So it can become very severe. We're all pretty familiar with the oral medications for erectile dysfunction, I think. Viagra and Cialis are the most common ones. Viagra just has a take it as you need it type dose. You take it about 30 to 60 minutes prior to intercourse. Viagra will last for about 4 hours, but one of the things that's really important is Viagra has to be taken on an empty stomach. So if you go out to a nice steak dinner and you have a glass of wine and you come home and you expect your Viagra to work for you, it probably won't, or at least not very well. So a lot of times when people come in and say, oh, this medication doesn't work for me, They just weren't told about that, and they're not using it correctly. Cialis has an on-demand form like Viagra does, where you just take it as you need it. Take it about 60 minutes prior to intercourse. It lasts longer than Viagra. It also has the low dose every day, like we talked about, that can help with urination and with erections. And this one is not affected by food. So it can be a better medication for some people. Stendra and Levitra are also out there. They're the same kind of medications. If Viagra and Cialis don't work, they tend to just be more expensive versions. We can try them. But oftentimes, once the oral medications stop working, we typically will move on to the next step in the treatment pathway. Vacuum erection devices are available. I don't generally recommend them, but they're available, so I included them here. But after oral medications stop working, we typically move on to the injectable medications. The most common one that we use is something called Trimix. This is an injection that you give yourself at home. You come into the office, we find the right dose for you, we teach you how to use it. You inject yourself about 15 minutes prior to intercourse. It will give you an erection. So the difference is with Viagra and Cialis, it won't just give you an erection. You have to be in a sexual situation for it to work. These injectable medications just stimulate erection. One of the negative side effects is you can develop priapism, which is that erection that lasts more than 4 hours. That becomes a medical emergency. If you have an erection that lasts more than 4 hours, the tissues in the penis can start to die. You've got to come to the ER. So that's why we start this medication in the office. We do small incremental increases, find the right dose for you, and if you have problems, you straight to the ER. It's uncommon, but it's possible. Once oral and injectable medications are no longer effective, there are surgical options for erectile dysfunction. So penile implants, again, are typically done by reconstructive urologists or people involved in sexual medicine. So these are things that I offer as well. The two main types are inflatable devices and malleable devices. The inflatable devices are typically preferred. It's a three-piece setup. So you've got this reservoir that holds all the fluid when it's not in use. There are 2 chambers that go into the penis, and there's a pump here that resides in the scrotum. So when you want to have an erection, you squeeze the pump in the scrotum. All the fluid from the reservoir will go into the chambers, and the penis will become erect. The nice thing about this is that when you don't want to use it, you can just turn it off, and the penis will become flaccid again. One of the other things is that it doesn't just automatically go down after orgasm. It's a mechanical device, so it can stay erect. This is typically the preferred device for people who are getting this type of surgery. There are also malleable devices, and these are just rods that go into the erectile chambers in the penis that you basically bend down when you don't want to use it and then bend up when you want to use it. Not as great as the inflatable ones, but for people who don't have very good dexterity in their hands and can't operate a pump, this can be a good option for them. The reason that these are our last line, I tend to only do this when nothing else works, is that the erectile chambers in the penis have to be cored out, essentially, to put these devices in. So if something happens and this device gets infected or it has to be removed, you will not be able to get a natural erection again after that. So this is not one of those things that you can sort of walk back from. So I generally like to make sure that people have really tried everything else that's available to them before resorting to this. Oh, and I did it too with the banana, but this is Peyronie's disease. So it is a kind of, we don't know exactly what causes it, probably some sort of autoimmune. We think it may be related to kind of an overreaction to microtraumas. But there's active and then quiet phases of Peyronie's. So the active phase can last for about 6 to 12 months, and that's typically characterized by penile pain, changes in curvature, and then it'll kind of go dormant for a while. The frustrating thing is that it can reactivate. If we do nothing, about 10% of people will get better, 40% of people will stay the same, 40 to 50% of people will get worse. Once the plaque is stabilized and we know the direction of the curvature, we can inject that plaque with something called Xiaflex to help break it up, and that can help correct the curvature. And then there are several different surgeries to be able to fix it as well. I don't want to go into, we're kind of running out of time, so I don't want to go into it too much. And then sexual dysfunction in women. So this is something that has historically been very understudied and undertreated. But loss of desire or low libido is common, decrease in vaginal lubrication, genital arousal disorders, vaginal stenosis or atrophy, menopause-related conditions, delayed orgasm and anorgasmia can happen as well, and there are a lot of different sexual pain disorders. We have gotten a little bit better recently about treating sexual dysfunction in women. I think there's still not as many options available as there are for men, but we're getting there. One of the things, a couple of medications have come out recently to treat hypoactive sexual desire disorder. So this is a persistently low or absent sex drive that's causing a lot of distress. It has to be present for more than 6 months. This affects both men and women. There's a lot of causes. Medications are a huge cause. Hormonal changes can cause this. There's a lot of health conditions. And then psychological factors, relationship issues, etc. So there are 2 treatments that are out for this right now. So one of them is flibanserin or Addy. So this is an oral medication. You have to take it every day. You have to take it several weeks consistently before you'll notice any changes or improvements. Results are fairly modest, typically results in about 1 additional satisfying sexual encounter per month compared to the placebo. You cannot combine this one with alcohol. So again, you go out to your nice steak dinner, you have a glass of wine, you come home, you want to take your Addy. You can have severely low blood pressure, dizziness, and fainting, so cannot be combined with alcohol. And Vyleesi is an injectable medication that you inject about 45 minutes before sexual activity, no more than once in 24 hours and no more than 8 times per month. It's only approved for premenopausal women, not postmenopausal women or men. Commonly causes nausea for 2 hours after injection. So that's exactly what you want to feel when you're using your injectable arousal medication. Using this repeatedly can cause permanent darkening of the skin, so something just to be aware of and let people know about prior to using this. There are a lot of different sexual pain disorders. I would recommend that people see a gynecologist and see if there are causes like endometriosis or pelvic inflammatory disease that we can treat the underlying cause. Pelvic floor physical therapy can be really helpful. And then there's a lot of products available commercially. I have no connection to this company whatsoever, but I generally I recommend them to a lot of people. They have a lot of different products available for vaginal pain and sexual pain. And they can be, I've had a lot of patients have really good success with these with their options. And then the other thing is just problems with desire, arousal, and connection. So I would recommend that you get a hormonal evaluation, see if there are imbalances in testosterone or estrogen. There's intimacy moons. Again, I have no connection whatsoever to this company, but I recommend it a lot. There's a subscription service that comes with a sex concierge, and they send you all of these kind of fun things every month and give you little homework to do, and they ship to Alaska. And they don't charge extra for shipping to Alaska, so I put that one on there because there's not a whole lot. Shipping to Alaska, I've learned, is really hard. So this one does no personal connection or benefit from you using this one, but this is one that I know and recommend. And then talking to a sex therapist. So this is different than talking to a psychologist, but there are people who specialize in sex therapy. I have someone who I worked with really closely in Los Angeles. She sees patients via telemedicine that live in Alaska. So if that's something that you are interested in, that can be really helpful with this. I think I managed to get through all my slides. So if anyone have any questions? Yes?
Back up a couple of slides.
Uh-huh. Which? Oh, yeah. Pelvic people. And then this was the other one. It's not a .com, it's .fyi. All right, any other questions? Okay, I'm going to run away then. So, all right.